Good afternoon, everybody. I'll be presenting on OCT angiographic characteristics of choroidal neovascularization secondary to posterior uveitis. As we know, a number of uveitic entities may be complicated by the development of CNVM, leading to decreasing visual acuity, which prompts urgent treatment. However, inflammatory choroidal neovascular membranes are challenging to diagnose clinically because of the presence of features like inflammatory lesions or intra or subretinal fluid accumulation, previous scarring, and pigmentation. On OCT angiography, fluorescein angiography and OCT, it may not be possible to differentiate active chorioretinal lesions and CNV because both may present with RPE breaks and subsequent infiltration of the outer retina on SD-OCT and late leakage on FA. Thus, the differences between the two are very subtle. And in such cases, a combination of fluorescein angiography, ICG angiography, as well as OCT angiography may be useful in determining the characteristics of the lesion. As we know, OCT angiography works on the principle of decorrelation to generate maps from retinal capillary plexus to choroidal vasculature. The role of OCT angiography in neovascular AMD has been very well defined for determining the microvascular details and activity. However, compared to neovascular AMD, the applicability, usefulness, and limitations of OCT angio needs to be evaluated in inflammatory CNVM. So we aim to analyze the characteristics of CNVM secondary to posterior uveitis on OCT angiography. This was a single center prospective observational study of 10 eyes diagnosed with posterior uveitis with CNVM on clinical examination, OCT, fluorescein angiography, and ICG as and when required. And patients underwent OCT angiography, either a 3x3 or panorama, depending on the area. Baseline demographic of the 10 patients had 10 female patients with 5 showing bilateral presentation. 4 patients had the cause of posterior uveitis was TB serpiginous like choroiditis. 2 were secondary to toxoplasma retinochoroiditis, and one each secondary to multifocal choroiditis, VKH, neuroretinitis, and APMPP. Coming to the first case, this is a 30-year-old male who presented with multiple scarred pigmented chorioretinal lesions with a small hemorrhage temporal to the fuzzy area. The same area was hypoautofluorescent on autofluorescence and showed leakage on fluorescein angiography. OCT confirmed exudation. OCT angiography shows a neovascular tuft with surrounding choriocapillaries alteration. On treatment with AKT, oral steroids, and intravitreal bevacizumab, there is improvement clinically as well as on OCT, and OCT angiography confirms the regression of the neovascular tuft as well as shows healing with choriocapillaries reperfusion in the surrounding areas. A comparison of pre and post treatment showing regression successfully. Second case shows a secondary to toxoplasmosis in which there is CNV close to the toxoscar. It confirms a lacy network with anastomosis and peripheral arcades on OCT angiography corresponding to the lesion. The color fundus image in this case shows a large fibrous scar centered at the macula along with a hemorrhage inferotemporal to the margins of the scar. SD-OCT reveals a PED with subretinal lesion, however fails to show any signs of exudation. OCT angiography confirms a neovascular network of CFAN morphology with multiple anastomosis. Post-treatment with intravitreal bevacizumab, the patient does not show any changes on OCT, however improved clinically, and on OCT angiography, we see that there are morphological changes with the vessels appearing more mature with larger caliber, however the size does not change much. Another case which shows CNVM secondary to a toxoscar, FA shows staining, OCT shows a subretinal lesion, whereas OCT angiography shows a very ill-defined network on treatment, whereas OCT shows the OCT shows resolved lesion. There aren't much changes on OCT angiography. Thus, to conclude with the results, CNV was identified in all 10 cases with a perilesional halo seen in 9 cases. On follow-up, 5 out of 6 cases showed changes in the morphology of the vessels. However, the network size decreased in 50% of the cases. Previous studies like Cheng et al. And Zahid et al. Have correlated fluorescein angiography, OCT and OCT angio features and established that there is that it can distinguish between inflammatory and neovascular lesions. Astros et al. Concluded in patients of multifocal choroiditis that OCTA diagnosis of that CNV diagnosis on OCTA is possible in 14% of the cases, which would be misdiagnosed as inflammatory lesions. We concluded that OCTA identifies underlying CNV, useful in monitoring treatment, and is an important adjunct to FA and OCT. Limitations of our study was the retrospective nature, limited sample size, and lack of uniformity in case selection with regards to previous treatment. Also, limitations of OCT angio are well known, as flow may not be detected, projection and motion artifacts, segmentation errors, and flow masking. To conclude, in patients with posterior uveitis complicated by CNV, OCT angiography successfully identifies underlying CNV, and although OCTA cannot completely replace FA yet, given the difficulty of differentiating inflammatory lesions, OCTA may provide a valuable method of managing patients with posterior uveitis, and a combination of OCTA, FA, and OCT should answer the question of treatment. Thank you.